Good morning. Today we're going to talk about malignant pericardial effusion, its diagnosis and management. Just to put it into context, primary pericardial disease is very uncommon, but we in day-to-day practice see up to 20% of cancer patients who have pericardial disease or pericardial effusion. And whilst most of these patients, or many of them, may remain asymptomatic, there are about 30% who will ultimately develop signs of cardiac failure and also the chance of a life-threatening cardiac tamponade. So this manifestation does have significant clinical significance. Generally speaking, pericardial effusion is considered to be something with poor prognosis, but I would say that the prognosis can vary very significantly, and I think that brings me to my first point, which is ultimately treatment has to be individualized. And what that means from my perspective is that you have to take into account both patient-related factors and also tumor-related factors. With respect to the patient, their performance status is very important when trying to decide on an appropriate treatment plan, as is the origin of the cancer, the histological subtype, the treatment options that are available, and the likelihood of response to that treatment. And ultimately, the appropriate treatment also is dependent upon the local experience at the treating institute. Tumors that we see most commonly with pericardial effusion, probably lung would be the top of the list, followed by breast cancer, but you also do see it with squamous cell carcinoma of the esophagus, melanoma, leukemia, and in the hematological setting, non-Hodgkin and Hodgkin lymphoma relatively commonly. With respect to pathophysiology, pericardial disease and effusion can be the result of direct extension of solid tumor, and in the hematological setting can sometimes result secondary to obstruction of lymphatic drainage, particularly if there is enlarged mediastinal lymph nodes. But not all effusions, even if there is a background of malignancy, are directly related to the tumor. Immunocompromised patients, such as these patients often are prone to opportunistic infections, some of which can cause an effusion. For example, CMV, TB, or Candida could do this. And we've heard a lot about the possibility of pericardial effusion as a result of treatment-related manifestation. Traditional chemotherapies can cause this, as can radiation therapy, as early as 2 months post-therapy, or as late as 12 years after treatment. And increasingly in the modern era, the increasing use of targeted agents, again, something we've heard about over the last day, are also showing increasing incidence of pericardial effusions. Just quickly to run through what might be the common clinical findings and examination in such a case, I think something to note is that you might not see any of these findings. But with respect to symptoms, shortness of breath of any kind, chest pain, cough, malaise, peripheral edema and palpitations, and with respect to signs, the characteristic pulsus paradoxus, which is characterized by a drop of systolic blood pressure of over 10 millimoles of mercury on inspiration without a simultaneous drop in diastolic pressure. Alternatively, tachycardia, peripheral edema, elevated JVP, hypertension, pericardial rub, reduced heart sounds. In spite of this long list, however, it's actually remains quite difficult to diagnose pericardial effusion based on clinical findings and examination alone. We're sometimes helped by a characteristic chest X-ray, which might show an enlarged silhouette, often in the case of large effusions or chronic effusions, often called the water bottle sign. And you sometimes have concomitant signs within the lungs themselves, either pleural effusion or lung infiltrates. Here's a typical ECG that we might see, either showing sinus tachycardia or a reduced QRS amplitude of less than 0.5 millivolts in the limb leads, and either nonspecific STT waves or atrial fibrillation. This just shows us pericardial effusion on echo. The echocardiography actually forms the backbone not only of the diagnosis, also of the follow-up, and is also inherent to the treatment of pericardial effusion. And here you can see the heart as well as the pericardial effusion, which has caused separation of the pericardial layers. I won't run through this, but essentially, in the event of cardiac tamponade, there are also echocardiogram findings which can help to diagnose tamponade itself. But in the case of pleural effusion without tamponade, it's actually only the separation of the pericardial layers that you might see, and what is referred to as the swinging motion of the heart, which I'll show you here, which is characteristic of the pleural effusion. Okay, so we have a pleural effusion, but given the different possible etiologies, it is becoming increasingly important to actually confirm that the effusion is of malignant etiology. And the backbone of this confirmation comes from both pericardiocentesis and pericardial biopsy. Pericardiocentesis, we can use just regular biochemistry to try and differentiate between a transudate and an exudate, whereas cytology can obviously help us in terms of identifying the presence of malignant cells. Bacterial cultures and PCR can help us identify an infectious etiology, and more recently a lot of research is being done into tumor markers. There isn't anything very specific to date, but there is some data showing high levels of CEA and high levels of CA72-4 are quite specific for a malignant etiology. Interestingly, VEGF is shown to be at very high levels in the pericardial effusion, and a high ratio between VEGF levels within the pericardial effusion relative to the serum might very soon be a diagnostic tool available to us. Pericardial biopsy, in my experience, is not done routinely, but again, can help us confirm malignant etiology, either via histology and immunohistochemistry techniques, or again, by identification of an infectious etiology. And I think the importance of this is just shown here nicely in this publication from 2010. What they did here was quite simply take all patients who were in a registry, a pericardiocentesis registry between the years of 1988 and 2008. They found 68 of about 300 patients who had an underlying malignancy. But what you can see here is that not all those patients, in spite of their background malignancy, do actually have proven malignant effusion. 42 of the 68 patients were found to have proven malignant effusion, and this was based on pericardiocentesis and pericardial biopsy. But another 26 of them were found to have alternative etiologies, and I think this is very important for us to emphasize, given that obviously the treatment plan has to be individualized based on the etiology, and also to make sure that we don't make inappropriate oncology treatment plans as a result of a misdiagnosis. Once we do have our diagnosis, however, I think the two main aims have to be palliation of symptoms and prevention of recurrence. And the best way to deal with these patients, in my opinion, has to be a multidisciplinary approach, whereby all the teams involved will give information with respect to underlying malignancy, the general prognosis of the patient, treatments that are available, and also the oncology treatments that are available to this patient. If we do talk about the treatment options, very briefly, we talk about single pericardiocentesis, extended catheter drainage, pericardial sclerotherapy, and 3 or 4 different types of surgical techniques, and I'll go through them briefly in turn. Pericardiocentesis, which we are most familiar with possibly, is done often in an emergency setting to drain fluid percutaneously with the assistance of echocardiography. It's usually done at minimal risk, with only about a 3% complication rate of either vagal hypertension, arrhythmias, and very rarely ventricular puncture. We can try and achieve a more complete drainage by inserting an indwelling catheter for extended drainage. And this often accompanies our pericardiocentesis procedure, and only removing the drain once we get a drainage rate of about 20 mils per 24 hours. And another important factor of doing this would be to allow us the opportunity of insertion of a sclerosing agent, the point being to help in the formation of adhesions, allow for the obliteration of the potential space between the two pericardial layers, and there have been many agents used for this purpose. Some of them are listed here: cisplatin, tetracycline, bleomycin, thiotaper, but I think probably cisplatinum is most commonly available and most commonly used nowadays. Surgical options: pericardial fenestration or window, pericardiectomy, pericardioperitoneal shunt insertion, and percutaneous balloon pericardiotomy. So the window is the formation of a window cutting an opening of a few centimeters in the pericardial layer to allow the drainage of the fluid from the pericardium to the pleural space, usually. Pericardiectomy is a more aggressive approach involving stripping of part or all of the pericardial layer, again in an attempt to allow drainage of the fluid. There's a possibility for shunt insertion and then drainage of the fluid from the pericardium to the peritoneum. And a more recent procedure, percutaneous balloon pericardiotomy, PBB, which is the insertion of a guide wire to the pericardium over which a balloon is inserted, creating the window which allows drainage usually to the left pleural space. Which of these are we to use? It's a good question because having reviewed the literature, it's of note that there are actually no randomized trials which compare one surgical procedure to another. And I think that's the second point that is important to emphasize here. Very recently there has been a systemic review of treatment of pericardial effusion. What they did here was analyze data from all articles and publications which used any mode of treatment to treat pericardial effusion. They were left with approximately 59 articles which could be quantitatively assessed, approximately 1,500 patients. And what they tried to do here was give an overall success rate score and complication rate score by amalgamating all studies which had used a given mode of treatment. And this table shows their results. 2 studies were identified which used single pericardiocentesis alone, and if you look in the control rate column, you can see that approximately 60% of patients were successfully controlled, meaning that they didn't need subsequent intervention for a recurrent pericardial effusion. Complication rates were low, but the other side of the coin is that 40% of patients did actually need a subsequent intervention for recurrent pericardial effusion. Extended catheter drainage, 6 studies here were found, similar control rates and slightly higher complication rates, but important to note that none of these complications were actually fatal with respect to pericardiocentesis and extended catheter drainage. They found 22 studies that referred to the use of pericardial sclerotherapy, and here you can already see a significantly higher control rate of 87%, and if you look at the papers that only talk about cisplatinum as a sclerosing agent, it's actually even higher, of about 90% control rate. But their complication rate were possibly surprisingly very high, and it's important to note that there was 1 fatality of constrictive pericarditis. The surgical papers, 19 of them, again showing extremely high rates of control, 93%, and to me, surprisingly low complication rates, as with the PBB. I think it's important to be cautious when we understand that this is a review, it's a retrospective review, there's no randomized control studies, and whilst the surgical interventions do appear to give a much higher level of control, it's very likely that there was significant selection bias here allowing for these results. Ultimately, we don't know if one treatment is superior to another, and I think one thing that was most striking to me with respect to this review was the fact that there's actually a complete lack of information with respect to the tumor type and also the subsequent systemic oncological treatment that was given post-treatment of the acute pericardial effusion. And that brings me to another paper. It was a small paper published in 2010 by Kim. And what they did here was take 100 patients, all of whom had had pericardiocentesis for a pericardial effusion, but all of which were suffering from different tumor types. And they tried to assess the outcome based on the different tumor types. And what you can see here very clearly, whilst the numbers are small, is that there is an obvious difference in overall outcome depending on the etiology of the tumor, the origin of the tumor. So adenocarcinomas of the lung, they had a 47% recurrence rate with respect to their effusion, whereas the breast cancer patients with effusion treated exactly in the same way had a 0% recurrence rate. Similarly, very obvious correlation between survival rates. The breast cancer patient, 1-year survival is approximately 60%, whereas the adenocarcinoma of the lung survival rate is down at about 25%. But it's not only the histology of the tumor that is important, it's also the subsequent oncology treatment that is given. And if you once they separated these patients into responders or non-responders to subsequent treatment, you again can see very obviously that survival is not only related to what we do to treat the pericardial effusion, it also depends on the overall prognosis of the patient and the subsequent oncology treatment given. The last point I want to make is that I think moving forward, it's very important for us to actually achieve optimal algorithms by trying to assess single disease cohorts. And this is nicely illustrated in this publication by Dr. Lestuzzi, who we're privileged to have in the audience, who did a multi-center study spanning about 30 years, assessing 4 different treatment options given to patients with lung cancer following pericardiocentesis. And the 4 different treatment options were either extended catheter drainage, systemic chemotherapy, local intrapericardial chemotherapy with cisplatinum, or a combination of the two, both intrapericardial and systemic chemotherapy. Now, I will add that there are caveats, significant caveats to these results, because this wasn't a randomized study. The physician chose which treatment was most appropriate for the patient, and obviously that means that we have introduced a significant selection bias, with poor performance patients probably only being more likely to only have drainage, whereas patients with, say, low volume extrapericardial disease less likely to receive systemic chemotherapy. But the results, I think, are still important, and they show very clearly that the group that fared worse was the group that only had drainage done without any additional therapy, and a statistically significant improvement was seen in patients who received systemic chemotherapy in combination with intrapericardial chemotherapy. So just to conclude, this is a poor prognostic sign, but the outcomes do vary differently depending on tumor types. We don't know what the optimal surgical intervention is, and we don't know what the optimal oncological approach has to be. But I think moving forward, tumor-specific research is the only way that we are going to get definitive algorithms which are appropriate for specific patients. And this can only be done via prospective studies which either compare to medical or to surgical approaches. Thank you.